Hello and welcome to the scientific paper we presented at the Radiological Society of North America annual meeting. The paper was a prospective analysis of endovascular coiling of anterior communicating artery aneurysms in the early post-rupture period. Most centers still consider ACOM aneurysms to be candidates ideally suited for surgery. However, surgery carries a significant risk during the first few days. It cannot be done from day 5 to 14, which is the period of acute spasm. When associated with other comorbid conditions and with increasing age, it presents an even higher risk. Poor results are known in patients presenting with grade 3 and 4 SAH. The ISAT study conclusively proved the safety and efficacy of endovascular coiling. Only 22% of the patients who received a coil were dependent or dead, as compared to 30% who underwent clipping. The purpose of our study was to evaluate the results of endovascular coiling of ACOM aneurysms and its feasibility as an alternative to surgery. 50 consecutive cases of SAH with DSA-proven ACOM aneurysms were evaluated by a 3D spin angiogram. All of them underwent endovascular repair with inert or bioactive coils. Follow-up angiograms were performed at 6 months whenever feasible. Of the 50 patients in our study, 38 were females and 12 males. Females in the age group of 41 to 50 formed the dominant group, closely followed by the 51 to 60-year age group. Smoking and hypertension were the commonly associated comorbid conditions. 22% of the patients were smokers and 80% of the patients were hypertensives on treatment. 58% of the patients we treated presented with grade 3 and 4 SAH and 42% with grade 1 and 2. Endovascular coiling was performed in all these patients regardless of the morphology of the aneurysm, vessel tortuosity, or the patient age. The results and immediate complications were then analyzed. Femoral artery approach was performed in all except one patient who underwent a direct carotid puncture due to tortuosity of the internal carotid and the anterior cerebral artery. This is the patient in whom we used the direct carotid access. The right CCA injection shows a tortuous cervical ICA with an acute takeoff of the ACA from the ICA. A direct CCA puncture was then performed under ultrasound guidance. This helped in negotiating the tortuosity of the vessels with better handling of the hardware, and the aneurysm was successfully coiled in an hour's time. Most of the aneurysms we treated were in the size ranging from 4 to 6 mm. The largest aneurysm we treated was a 14 mm size aneurysm. The treatment technique we use is largely dependent on the fundus to neck ratio. When more than 2, it is termed as a narrow neck, and when less than 2, it is termed as a wide neck aneurysm. The various treatment options in endovascular coiling of aneurysms are shown here. After the guiding catheter is placed in the ICA, a microcatheter is used to intubate the aneurysm. In a narrow neck aneurysm, once the microcatheter is placed, coils of decreasing size are sequentially placed until no residual filling is seen. However, in a wide neck aneurysm, the coils tend to prolapse out into the parent vessel through the wide neck. This can be overcome by using a hypercompliant balloon which is placed across the aneurysm neck. The balloon is then inflated and coiling performed as usual. This prevents the coil prolapse into the parent vessel. The same can be achieved by using a stent which is placed across the aneurysm neck, thus preventing coil prolapse. "30% of the aneurysms we treated had a fundus to neck ratio of more than 2. In 15%, a balloon remodeling technique was used. Complex 3D coils were used in the other wide neck aneurysms. The image to the left shows a narrow neck aneurysm which was subsequently coiled without any balloon remodeling or a stent-assisted technique. As discussed earlier, with a wide neck aneurysm, the coils tend to prolapse into the parent artery. A hypercompliant balloon is placed across the aneurysm neck, and this shows the post-procedure angio with complete embolization of the aneurysm and a normally filling ACA and its branches. We had 3 deaths in all, one of which was a non-table rupture, the other was a coil prolapse with bilateral ACA stroke, and one with an ACA infarct which was thromboembolic. This was the case wherein we lost the patient due to a coil prolapse into the ACA post-procedure. This was a complex trilobed aneurysm which ruptured on table. The procedure was however completed. We unfortunately lost the patient due to a large intracranial hemorrhage the following day. Fatal clinical vasospasm was seen in 2 patients, both of whom were males and smokers and had presented with grade 3 SAH. This is a 3D spin angiogram of the patient showing the ACOM aneurysm. The post-procedure angio showed no significant residual filling. We however lost the patient on the 11th day due to severe vasospasm. Follow-up angiograms at 6 months were performed in 76% and showed no significant recanalization. This is a pre and a post-procedure angio showing no residual filling. Follow-up angiogram at 7 months shows no recanalization of the aneurysm. So to conclude, ACOM aneurysms are prone to rupture regardless of their size and need to be treated. The results of endovascular treatment of ACOM aneurysms are in no way inferior as compared to surgery and can be considered as first line of therapy. The results of endovascular coiling closely match with those of surgery in clinical grade 1 and 2 and is a feasible option in patients with grade 3 and 4 SAH, which are in fact contraindications to surgery.